Hi, everyone. I'm Nick Trevellis. I'm one of the co-chairs for the research committee on AOCPMR. This is our May Journal Club. Dr. Cara Vernacchia is currently explaining osseointegration with amputees, specifically above the knee amputees. Just went over K levels on various prostheses and importance of properly fitting prostheses for amputees.
Yeah.
Dr. Vernacchia, take it away.
Okay. So essentially, osseointegration is placing this metal rod up through the femur and then having it come out the skin. And then that metal rod contacts with the prosthesis itself. So you don't have as much of the contact of the skin on the prosthesis. And the idea behind this is that there's then going to be less skin breakdown. And osseointegration is actually very well established in dentistry, but it hasn't really gained much traction in the orthopedic world. So this is really kind of an interesting idea for patients who have issues with prostheses. So some of the main advantages that have been postulated include improved stability and comfort, increased hip range of motion. It's easier to put on and off, better body perception, because if you envision that they have this metal rod that's actually going up through their bone, a lot of their proprioception may be improved. They also are postulating increased walking ability, increased function, and an improved quality of life. So this is just another picture of what this osseointegration looks like and what a prosthesis would look like. And then as you can see on the right with the radiograph, the metal rod actually goes up pretty far, almost to the femoral neck, goes up pretty far there. And then, yeah, so the one on the left in A is just an example of like what a common prosthesis would look like. So the main aim of this paper was to investigate whether walking ability and quality of life of subjects with OI are superior to walking ability and quality of life of the same people with conventional socket prostheses. So for our methods, so they did a prospective case control study. They took patients who had transfemoral amputations and they had a prosthesis already, but they were experiencing socket-related skin and residual limb problems, which was contributing to reduced quality of life. They weren't able to wear their prosthesis as much, and so they were having some problems with this prosthesis. They had some inclusion criteria, which is on the left, and they essentially had the patients answer these questions that, like for example, have they already been evaluated by a rehab physician to make sure that their prosthesis is as adequate as it can be? How much of their quality of life is impacted by this prosthesis? Are they using it for less than 50 hours a week? And are they walking less than 2 kilometers? And if we think back to those K levels, our K2 ambulators are community ambulators. And our hope for them is that they're going to get up in the morning, put on their prosthesis, and wear it for the entire day. And so if you consider that these patients are wearing them for less than 50 hours a week, they're not wearing it for a full 12 to 14 hours a day. And so that's their inclusion criteria. They excluded anyone with an inadequate prosthesis, meaning that their prosthesis could be modified to maybe improve their outcomes. They also excluded anyone with a residual femur that was too short. So if it was less than 8 centimeters, they didn't have enough distance to place that intermedullary rod. Amputations that were caused by diabetes or vascular issues. And so they did exclude anybody, which is a lot with any sort of diabetes or vascular issue, which is a large population of patients that need amputations. And then, I'm sorry, I have all of our pictures at the bottom of my screen and I can't move it to see what the bottom slide. Oh, there we go. Okay. Or any severe cognitive or psych disorders. Sorry, I'm trying to move everybody's faces out of the way a little bit. There we go. Okay. Okay, so what are your thoughts on the inclusion and exclusion criteria? Does anyone have any input? I'll go back to the slide. Do we feel like this is a good representation of the amputee population, or does it seem pretty specific?
Feel free to unmute or put your responses in the chat.
So
I can mention a little something. I mean, obviously there were limitations with the study with the considering the exclusion criteria. But that being said, I think it wasn't terribly limiting in terms of, would it have been nice to include people with broader lengths of the prosthesis? Absolutely. Would it have been nice to have a little broader of a population to be able to include in the study? Absolutely. But the problem is when you go broader, then oftentimes it's harder to kind of interpret your data as cleanly as possible. And if you have people who did have a larger variety of lengths in their prostheses, that could make it challenging to determine problems that were arising in the data. Was that because of length of the prosthesis, or was it because of something else, as opposed to having a slightly more homogeneous group? I mean, you want some variability, but I think they did as good a job as they could, considering.
Yeah. Yeah, no, I totally agree. I think although they didn't really include a large subset of patients that do get amputations, like you said, they were really trying to control it and create as homogeneous of a population as possible in order to really narrow in on certain variables. So yeah, so I agree. Okay, so as far as the surgery goes, it's actually a two-step surgery. The first step, they shortened the residual limb to 20 centimeters proximal of the contralateral knee joint space. So they tried to make all of the residual limbs about the same length. They then inserted the intramedullary implant, and then they actually closed the fascia and skin over it. They gave them some antibiotics and waited essentially for it to kind of heal over. Step two, then, about 6 to 8 weeks later, they reopened the skin and the fascia and accessed that intramedullary implant, and they placed this transcutaneous unit that was then bolted to the implant, and then that was what stuck out of the skin. And so for the rehabilitation part, which is the part that we're interested in as PM&R physicians, they did twice a week group training sessions for 2 hours for 6 to 8 weeks. 1 week after the completion of both surgeries, they were able to bear 50% body weight on a short pylon, which is essentially like a shortened leg, a shortened prosthesis that was attached to the OI unit. 2 weeks after, they were able to do full weight-bearing exercises on the short pylon. 4 weeks after surgeries, they attached the prosthesis to a transcutaneous unit and they did progressive loading. And then they gradually increased the amount of weight bearing on the implant and started doing more locomotion exercises. And 2 weeks later, they were able to bear full body weight on the implant. So essentially, this was taking about 6 to 8 weeks before they were able to bear full weight on the implant. And if we think about patients who get amputations that end up with more of the typical type of prosthesis, this timeline is pretty similar. When a patient has an amputation, they'll typically go to acute rehab for a couple of weeks. They will probably not get fitted for a prosthesis for about 6 to 8 weeks, and then they start the rehab from there, which can take weeks as well. So timeline-wise, it's pretty similar. Outcome measures. So they evaluated patients preoperatively with their initial prosthesis, and then 12 months after surgery and the completion of rehab, they evaluated them again. They looked at quality of life using the questionnaire for persons with transfemoral amputations, or the QTFA. They looked at prosthesis use and how many hours a day they were using it and how many hours a week. They also looked at walking ability using the 6-minute walk test and the timed up and go test, which I'll go over on the next slides. And they also evaluated oxygen consumption during treadmill walking. They also noted that they let patients use a rolling walker or a cane or whatever type of walking aid that they needed. So the 6-minute walk test is something that you'll hear a lot of therapists talk about. And so it's something that comes up a lot in PM&R. So I wanted to go over it. It's essentially exactly what it sounds like. You let the patient walk for 6 minutes and you track how far they've gone. And so you can have them just walk around the floor if they're on an inpatient unit, or if they're in a therapy gym, just have them walk back and forth from point A to point B. And so you're essentially just trying to see how fast or how far can they get in 6 minutes. For the timed up and go test, the patient starts sitting. They do a sit to stand transfer, and then they walk 3 meters, they turn around a cone, and then walk 3 meters back to their seat and go from stand to sit. And so this is, again, another important outcome measure that we use in PM&R and the therapists use very frequently, because you're testing their ability to do a sit to stand, a stand to sit, and then also their ability to walk straight, do a turn. So it's testing a lot of different things, and they time how long it takes and can compare then from different time points. For the data analysis, they did paired t-tests and a Wilcoxon test to compare before and after osseointegration. So for the results, they had 22 overall subjects. 20 of them were trauma-related amputees and 2 were from a tumor. 21 had transfemoral amputations, and 1 actually had bilateral transfemoral amputations. The mean age was 46. There were 18 males, 4 females. The average was about 16 years out from amputation. So a lot of these had amputations earlier in life and then had been, experiencing pretty significant skin issues or quality of life issues from their current prosthesis and had been dealing with that for years. No participants were lost to follow-up. What are your thoughts on the participants? What do we think about the patients not being lost to follow-up? Is that a good thing, a bad thing?
I have some ideas, but I want you guys to be able to answer too. Maybe speak up.
I think it's pretty shocking that out of 22 subjects, you didn't lose anybody in follow-up.
Yeah, agreed. So I think that brings up kind of a point that's pretty prevalent in research is a lot of times you have patients that don't follow up and you end up, stating that as one of your weaknesses or your limitations. The fact that there were no patients lost to follow-up is really good for the data in that we're able to really compare A to B for each patient and we have a larger subset. But it does then make us think that these patients were very motivated. They maybe were of higher socioeconomic status, so they didn't have issues getting to the clinic or getting back for follow-ups. Those types of things were kind of going through my head when they said that no participants were lost to follow-up. So it's maybe not truly indicative of a clinic patient that we maybe would see. And so 12 months after their surgeries in rehab, they evaluated the patients. And so on the left side is the socket information, and then on the right is the osseointegration. So left is socket before their surgeries, and then the OIP is going to be 12 months after their surgeries in rehab. So the QTFA global score, which was their quality of life score, went up from 39 to 63. The prosthesis use, they were only using the prosthesis for about 56 hours a week. And with the osseointegration, they used it for 101 hours per week. So that's a pretty significant increase. The 6-minute walk test, the time or the meters went from 321 to 423. So that increased. The time to up and go went down from 15 to 8. And their oxygen consumption decreased from 1330 to 1093. And so all of these were statistically significant, as you can see on the right, as evidenced by their p-value being less than 0.05. And so this is essentially saying everything that I had just said on the last slide, but some things to point out is their prosthesis use significantly improved by 45%. And so they went from 56 hours to 101 hours. So they almost doubled their amount that they were able to tolerate the prosthesis. Okay. And so one other thing to note is that 8 patients had mild infections of the soft tissue. And a lot of these infections were ones that were able to be eradicated with oral antibiotics or a short bout of IV antibiotics. This paper did not go into the specifics of the soft tissue infections or any other adverse outcomes, but this is found in another paper that they published if anybody is interested. And then of note, the average 6-minute walk test and prosthesis use did not change for those with soft tissue infections compared to those without. So even if a patient ended up with a soft tissue infection, it did not necessarily change their outcomes in function. Okay, so for the discussion, they essentially are saying that osseointegration improved walking ability and quality of life in subjects with transfemoral amputations who had residual limb skin problems. Their global score was higher. They were able to walk further and faster while using less energy, and they wore their prosthesis for more time. So these are all really, really great functional outcomes. Some of the limitations they cited is that all patients presented for follow-up, and we already talked about that, but when you have all patients following up, it's maybe not as indicative of the general population as we would want it to be. It's also unclear if these findings can be extrapolated to those without prosthesis-related complications. And so, these patients were probably pretty frustrated with the skin issues they were having and were willing to try the osseointegration. But if you have a patient who really likes their prosthesis, they're able to wear it for the full day, they aren't really getting skin breakdown, then placing an intramedullary rod into their femur is probably not something that they're going to consider and probably not something that the surgeons or the rehab physicians would be recommending. There's no data about infection rates and technical failures in this study, but as I said, this information can be found in another study if anyone's interested. And this study only had about 20-something patients, and so larger studies are needed with longer follow-up, more than a year, in order to really see how their outcomes are and if they end up with more complications down the line. And use of walking aids was not measured, although they did say that they allowed them. But it might have been interesting to see, were the patients were more of them using a cane and a walker with their osseointegration? Were they using those assistive devices less often? So that may have been something interesting to look at. And osseointegration, in conclusion, is a suitable intervention for individuals with transfemoral amputations performed for trauma or tumor who have reduced prosthesis use, and in 1 year following surgery, they had increased walking ability and quality of life. So my thoughts, as we had said, most patients we see with amputations are from vascular or diabetic related complications. And so if I think back to my prosthetics rotation, where we were seeing a lot of patients with amputations, a lot of those patients, I would say probably about 90% of the patients are vascular or diabetic related. And so the tumor and the trauma related amputations are definitely less often. And OIP may not be suitable for the highest functioning amputee athletes. And so this is something that I've actually talked to one of my attendings about, but he said when it comes to osseointegration, you actually can't really successfully do that for a patient who's going to be more of a K4 level. So those patients who want to do sports or high level activities, OIP may not be the best option just because of the way that it interfaces with the bone. Okay, so thoughts or comments? Has anyone seen patients with amputations or with osseointegration? And then I'll also just open it up to see if anybody has any questions for me about PM&R or my residency program, applications. I'm happy to answer any questions.
Yeah, I guess if nobody has any questions about the paper, I'm definitely curious about how you got from A to B to Shirley Ryan.
Yeah, okay. Specifically from med school or?
Yeah, from medical school.
Yeah, so I'm assuming all of you are DO students, is that accurate? Yeah. Okay, Nick, are there ever MD students here?
I think most people are DO. There might have been a couple MD when I was going through the list, but I think most are us.
Yeah. So I think especially coming from a DO school where it was hard to get PM&R exposure, I did a lot of sub-Is, and I think that really helped me to get to know the field and have a lot to talk about on interviews. I was lucky in that I actually did a program at Shirley Ryan between my first and second year of med school that was a research, and it was mostly inpatient based program for 2 months. And so I guess I kind of got my foot in the door that summer. But I do think as a DO student, there are some unique challenges, and I would recommend that if you are a DO student, you try to see as much PM&R as you can. I think when you're applying and interviewing, they do like to see that you're dedicated to the field, that you've really taken the time to get to know the different facets of the field and all the unique aspects of the field, because it is such a broad specialty. I don't know if that totally answers your question.
Yeah, it does. I actually got accepted to that first year program, but my summer break was only 5 weeks long, and they told me I couldn't do the virtual portion of it.
No.
But,
That's such a bummer. It was a really great program. If anyone here, well, I guess it's too late now for the first years, but if anybody knows of someone who's starting med school, it's a really great program. Even if you're not interested in PM&R, it's still just a great program in order to be able to get some inpatient exposure that early in med school.
Additionally, just a little bit of a plug for AOCPMR, our research committee. We host monthly journal clubs, and we're going to start coming out with a little bit more content once after board season is over, once July kind of rolls around. And then additionally, our education committee has been really awesome at doing a subspecialty series. And so you can look online. We have recorded events from their past events, and they have upcoming events as well, advertised on Twitter and our Instagram feeds as well. They have some ultrasound stuff with MSK and physiatry related disease management coming up as well. They've done subspecialties on pain. They have some pediatric ones coming up. I think they've done sports medicine. They've got a lot of stuff. So if you're looking for more physiatry content, AOCPMR, we're working on getting you covered. So
That's great.
just an obligatory plug. Sorry, guys. There was other questions related to PM&R questions. When I was going through the Google form, there's a place where you can put in questions. And I know there was, I don't know if they're here right now, but there was an intern who was a physiatry intern who was very excited to, I think, either be starting her internship or starting her PGY2. And she was asking about resources that you might recommend for starting PGY2.
Yeah, no, that's a really good question. Have you guys heard of the Cougarillo book? It's essentially it's the main board review book. It's written by Dr. Cougarillo, but it's our main board review book. And it's a thick, it's a thick book, but I would recommend as a med student when you're going through your sub-Is or through your PM&R rotations to read the sections on the rotation that you're in. But then also as a PGY2, although it's really hard to find the time to study, if you do or want to have some resources, that is also really helpful. And it's sort of written in almost like a bullet form. It's not like a paragraph form, and so it gives you that high yield information. And then my advice for anyone starting PGY2 year is, the medicine. You've already done a year of internal medicine or surgery or whatever you end up doing, or transitional year, and just trust that you know what you're doing from a medical standpoint so that you can try to focus on the rehab. And that's easier said than done, but you are equipped, and just be confident in yourself and trust your instincts when it comes to medically managing those patients, because they can be complicated. But yeah, it is definitely a transition going from internal medicine or surgery where you're an intern to then being a PGY2 in a rehab hospital, because a rehab hospital is very different and you have different resources.
Awesome advice. Thank you for that. And then the only other question that I saw in the Google form was there was a medical student asking about, I think, just some exposure stuff. As a physiatrist, were there cases that you came across in your physiatry related rotations or your residency program where it was kind of out of the ordinary that medical students might not think of when we first think of PM&R?
Oh, that's a good question.
Yeah, that's so too.
That's a really good question. So there is this small facet of PM&R that's women's health rehab. And so I don't know if very many of you have heard of that, but essentially it's dealing with pelvic pain. They do a lot of referrals to pelvic floor therapists. They can treat constipation or GI issues, chronic pelvic pain, endometriosis, those types of things. And a lot of times they also deal with prepartum or peripartum, postpartum issues. So that's one field of PM&R that I think a lot of people don't know about, and is sort of an interesting thing, especially if someone liked their OB-GYN rotations and maybe wanted to try to mix OB-GYN with PM&R. I'm trying to think what else I've been maybe surprised by seeing in rehab. I think that is probably like the main one, I would say. Yeah.
I have a question.
Mm-hmm.
And thanks so much for doing this. It's my first one I've gone to. It's been great.
Yeah.
So I just looked up a couple weeks ago that there's a dual PM&R and pediatrics residency program, a few of them. And I think you were doing a pediatrics fellowship. Mm-hmm. So I guess what would you say is like maybe the advantages or disadvantages of each of those?
Yeah, absolutely. That's a really good question. So when I was applying, I thought I maybe wanted to do peds rehab, but I wasn't totally sure on it. So I didn't end up applying to them. I think you might know better than I do. When I was applying, there were maybe only about 4 or 5 programs in the country. And so essentially for that, you'll do 5 years of your residency, and you will be dually certified in both pediatrics and PM&R. And then you'll do 1 year of an additional fellowship in pediatric PM&R. So you'll be then like triple certified, I guess it is, in pediatrics, PM&R, and peds PM&R. So you could leave practice and then just go do regular pediatrics. You don't even need to do the rehab component of it. So that is the benefit of that, because the route that I'm taking, I'm just doing the general PM&R route, which is 4 years, and then I'll do a 2-year pediatric fellowship. So I'll be certified in PM&R and peds rehab, but I won't have that pediatric residency training, if that makes sense. Yeah. So I would say that's the one benefit to doing the peds, the combined programs. But I would say the downside is you're very much, you have to go to one of those few programs. There's very few spots. If you're geographically constrained, that might be a problem. And then also, if you're not totally sure you want to do peds rehab, it may pigeonhole you into doing it, although you will still be board certified in plain PM&R. So you could still do general from that, but I think it does sort of pigeonhole you into doing peds rehab. Yeah.
That was very helpful. Thanks.
Yeah, no problem. And I think looking back, in the end, you end up, it's 6 years for both. So that's not really a difference. I think I'll still be able to do what I want to do in my practice without needing that pediatric component. So it really depends on what you want to do with your practice. And I know it's so hard to even think about that as a med student because you just haven't seen enough to really know what you want to do. And I still don't know what I want to do totally. But I think that's something to consider is, could you see yourself doing just straight pediatrics, or do you want to be the pediatrician for these patients as well, or do you want to just be their rehab doctor? Yeah. Excited to hear that you're interested in peds. It's a small field.
Yeah, I love kids and I love rehab. So I'm like, well, put the two together and
Great.
It's a good match. So
Yeah, that's perfect.
I did have a question more so on like rotations for fourth years.
Yeah.
Kind of, are there any like recommendations like for like fourth year rotations or like rheumatology, radiology, or anything out of the, ordinary versus like inpatient versus outpatient rotations? Any recommendations that you might have for, for us to do, I guess, that are like non-specific to PM&R, I guess?
Yeah, that's a really great question. I think you named some of the main ones. So like rheumatology, I think is a good one. Neurology is one that I wasn't required to do, and I guess you go to my med school, so you're probably not required to do that third year either. So that's one that I would recommend if that's not a requirement, or even if you can do more weeks of it than your requirement, because there is so much neuro in PM&R. Also, doing outpatient sports medicine is helpful just to get some more practice on your MSK exams. Trying to think what else. This might be more for if someone's interested in peds, but I did a neonatal ICU rotation my fourth year, which was really great, and I loved that and felt like that was a really good kind of segue into PM&R, because a lot of the patients that you see in pediatric PM&R and even in adult PM&R have deficits that started from the NICU. So that's something that you could consider. Yeah, I would say those are kind of the main ones. Yeah. And then also radiology is good. If you can do like MSK or neuro radiology and spine imaging and that type of stuff, that would be helpful too.
Thank you.
Mm-hmm.
Well, people might be thinking of other questions. I'm just curious about the going back to the paper. Sorry, you mentioned there was another study that investigated the like soft tissue issues that some of these patients were having in the study. Do you have that on hand by chance?
Hold
if
on.
not, don't worry about it. It's fine. I'll look it up on
Okay.
I'm just
I can send you the name of it. But if you look up the same authors, it was also done in Sweden on osseointegration. There's also very few articles about osseointegration from Sweden specifically, and you should be able to find it. It was published in, I want to say it was published in JBJS, the Journal of Bone and Joint Surgery. Yeah.
I guess I have a question about the osseointegration too. So I guess if it seems like it really improves quality of life, I guess is like the biggest limitation for patients doing the procedure, just merely going through the procedure itself, I guess, even if maybe they don't have problems with wounds on their other prosthesis, it's just not worth to go through the procedure if they have the better movement mobility.
Right. I think if they're already able to function and do most of what they want to do in their daily life, I think undergoing the surgery, which is a pretty big undertaking, would not be worth worth the potential benefits. So yeah, I think that's kind of why and I think that's also why they target some of the younger patients with the tumors or trauma-related injuries, because there is less likely to be an adverse outcome. Because yes, there definitely is an increased risk for infection, and although it may not adversely affect their outcomes, it's still not pleasant for a patient to be developing an infection or having an adverse outcome. But then again, these patients that they chose were already having adverse outcomes from their conventional prosthesis, so it kind of made sense for them in that instance.
I did find that other article, by the way.
Oh, awesome.
And yeah, it's the same authors for the most part, and they looks like they found that there was even though functionally they were doing really well, people were still using walking aids, and then they said the presence of phantom limb pain and pain in other extremities was unchanged. So that to me kind of makes sense with what they're doing.
Yeah.
But yeah, it'll be fun to read about that. Thank you all so much for your time. If there are no more questions, everybody enjoy your evening. And Dr. Vernacchia, thank you so much for being so generous with your time and your expertise and knowledge of PM&R and physiatry and pediatric physiatry. We greatly appreciate it.
Absolutely. I just threw my email in the chat. If anybody has any other questions about PM&R, want to chat further, I'm happy to chat. So yeah, feel free to reach out.
Awesome. And if you can't catch it in the chat, don't worry. I'll be following up the email that I sent to everybody with the Zoom link with Kara's email if anybody has any questions, if that's okay, Kara.
Yes, that is totally fine with me. Yeah.
All right.
All right. Thanks everyone for coming.
Yeah, thank you so much. Appreciate it.